to go over. So we'll start with just basic anatomy, and then we'll go over a few other things, and then finish up the last of the slides with what we expect to see kind of coming up this fall with school starting back up. And then after that, what I have planned is we're going to split off into groups, so about 5 or 6 people in each group, and there's 5 stations, but I want everybody to hit 4 stations, and then depending on what your license status is, are the stations that you need to be hitting. So station 1 is going to be in the day room, 2 is going to be in this back corner, 3 is going to be in the back hallways. You're going to 902's office, and then 4 is going to be in the kitchen, and then for 5 we have up front here. So just make sure you're hitting 4 stations, and then there's an attendant at each one, and just get their signature and check off that. And then the top portion of this is going to be your little quiz, review, note thing, whatever you want it to be. So you can fill that out as we go through this. When you guys are done with your 4 stations, just go ahead and start a stack right here, and then there's an evaluation form that I need you guys to fill out and then turn that in when we're done. So just to go ahead and start with a review of the anatomy, we got our upper and lower airway. So upper airway, the main functions of that is to warm, humidify, and filter. And then as we move into the lower airway, that's where we have gas exchange that occurs. So upper airway has our nasopharynx, oropharynx, and laryngopharynx, and then it turns into the lower airway at the glottic opening. And so I know this is review for everybody, but found something that says like understand the anatomy is like a map that directs us. So whenever we're trying to do our innovations and we're looking for our landmarks, we really need to know where everything's located. It's going to help us have a successful innovation. And then just something about the stations I want to mention one more time, but there's lots of different tools out and different ways that you can innovate and practice. So really just take your time when you're going through them, and just kind of keep in mind that you're going to get out what you put into it. So really just kind of mess with everything and try different things. If you have different techniques, try something new, or if you're used to one thing, just try something else. So depending on what your method is, if you're using a Mac blade or you're using King Vision, you're going to try to hit this vallecula, that opening above the epiglottis. If you're using the Miller blade, then you're going to try to lift that up. And then depending on different patients that you have, then we're going to use the Miller blade for most of our pediatrics because their epiglottis, as we know, is a lot bigger, a little bit harder to control. So we're going to try to take control of that. So I remember when I was in school, I had a nurse that kind of broke everything down pretty simple and talked about, you know, air goes in and out, blood goes round and round, which again breaks it down. But the thing about the airway is, in order to treat what's going on with someone's airway, we have to know where the problem is. So yes, air goes in and out, but do we have issues with the alveoli? Is there some type of constriction? Is there some type of trauma to the airway? And if there is, where is it? Because that's going to adjust how we're going to treat the patient as well. And then any pneumothorax or wherever that is, it's just more things that we have to consider, and so we can treat our patient. The next slide is something that I think all of us probably don't do the best at, and it's using our BVM, because a lot of us we're supposed to be using the 2-person for bagging, and I can't remember the last time that I had 2 people bagging a patient on any of my calls, but that's what we're supposed to be doing, right? So there's lots of times where we have too many people there that are just standing around, but this is something that we can utilize 2 people for to make sure that we have a good mass seal. So the average tidal volume per patient is about 500 milliliters, and that's the average amount of air that we take in, breathe out. Our BVMs hold 1,600 milliliters, so when you think about it, that BVM holds over 3 times the breath that we should be giving to somebody. So when you think about how much air is in the bag of the BVM, we really need to only be squeezing just a tiny amount because we want to make sure we're not overinflating, and we're just looking for that chest rise and fall. When it comes to stomas or trachs, we can use a pediatric mask to cover the opening and attach that to an adult BVM. We can even just take off the mask if they have the trach in place and use that to connect to it, to the BVM to connect to their trach, and we can ventilate the patient that way. And then the other consideration that we need to think about are children. So they should have about 1 inch of padding behind their shoulders if they're 3 years or younger. And then also if you have pediatric patients, make sure that you're enabling that pop-off valve so we don't overinflate. All right, so if we are using any BVM at all, then we should have some type of airway adjunct in there, or even if we're getting ready to intubate or do any procedures at all more advanced, then we should have an airway adjunct. So we have our NPAs and OPAs, and how do we measure NPAs? Corner of your nose to the earlobe. And then what about OPAs? Corner of your mouth to the earlobe. And then while we're bagging, we need to make sure we're considering what their normal respiratory rate is. So infants are about 30 to 60, toddlers are 24 to 40, preschoolers are 22 to 34, school-age children 18 to 30, adolescents, which is 13 to 18 years, is 12 to 16, and then adults is 10 to 12 until we establish some type of advanced airway or tube, and then we're gonna start going to 8 to 10 breaths per minute. But in addition to what their normal respiratory rate is, we're also going to adjust based on their vitals, what's their end tidal look like, and like that. So if we've considered our other airways, we know this patient isn't going to do, a nasal cannula is not going to do what this patient needs. The nasal cannula delivers 24 to 44% of oxygen. A non-rebreather can deliver 100% of oxygen. But when we need to make the decision to go to an intubation, we need to evaluate the airway, and we do that with LEMON. So LEMON stands for look. L is look. You're going to look at your patient, and a lot of you guys have been doing this long enough that you know just by looking at them that this is going to be a difficult intubation. You guys have had enough exposure to different airways and what to expect, and you know this is going to be a difficult one. E is evaluate, and so we're going to use the 3-3-2. So the 3 fingers side by side, if you can put them straight up and down in their mouth, if they can open that wide, that's 3. The other 3 is from under your chin, from your base, or from the tip of your chin to the back of your neck there. And then 2 is going to be from the base of your neck to the thyroid cartilage. M is Mallampati. So there's 4 classes of those. 1 is going to be the easiest airway intubation, and 4 is going to be your most difficult one. And then N is neck mobility. Check out the Mallampati on that. And it was Shark Week last week. So this is the 3-3-2 rule right here. So like I said, the 3 fingers in the mouth, the 3 fingers under the chin, and then the 2 fingers from the base of your chin, or base of your neck to the thyroid cartilage. And then down here we have our 4 classes for the Mallampati. So like I said, 1's going to be your easiest intubation. That's where you can see most of the airway. 4 is going to be your most difficult. And then they said that most of the issues that are class 4 is just due to positioning of the patient. So if you have a patient that's a class 4, then try repositioning them, move them to a different area, anything you can do to get a better view. The differences between class 2 and 3 are you have these kind of pearl-like structures down here, they're called retinoids. So if you can still see those, they're considered a class 2. Once you can't see the retinoids anymore, that turns to a class 3. And then national study shows that there's really only 2% of difficult intubations. So we just need to, if we think we have someone like that, we need to use all of our tools, evaluate, set our patient up, because if we only have 2% of airways that are difficult, then maybe it's just something that we can adjust so we can have a better intubation attempt. All right, I got 2 videos, and they're really short, they're less than 2 minutes, and they're both really, really corny, but there's a couple really good things I want you guys to notice. They're going to be intubating and suctioning, so with our decanto suctions, they just have some different techniques for those. So.
Looking for a reliable and affordable car that fits the needs of your entire family? You're a
Ultimately have you take the, ready? Okay, so water will be going on. I see a whole bunch of fluid. The airway keeps filling up. I need suction. Suction is on. I have it in here. Every time I just take this out, I can't even keep it in because it's coming through the cords. So I'm going to instead pass this to the trachea. In here, take the stylet out of there, please. Take the suction catheter off.
So to that suction
catheter off. Pull it, pull it, pull it. It's dying. Back into the bougie. Back into the bougie. Back in. There you go. Slide that in. Beautiful. Slide it. Keep going. Keep going. Keep going. Oh, it's there? Okay, cool. Go ahead and pull the this out. I got the bougie. Go ahead and pull the tube.
Tube with no stylet.
Cool. And I'm going to push this through. You get the bougie. To the teeth. Boom.
So that's important. We know our tubes, we know how deep we usually go in an adult, right? 802, 22 at the teeth. Everybody's impressed, everybody's impressed. How about a round of applause?
Alright.
Alright, I'm gonna give you guys a brief.
So that's one way. If we do have a patient that needs a lot of suctioning and it just is their airways refilling faster than we can suction and get an intubation done, what they did here is they took that decanto and they just stuck it right down into the trachea, and then they went ahead and put a bougie in there, removed the decanto, and then placed a tube over top of that. So that's one method that they had, and this one has a really cool song with it. So. So real fast, what they did here is, so they're using their King Vision, but they started suctioning over on the right side and with the King Vision, and then when they had it cleared out a little bit more, they took that suction and they moved it to the left side of the King Vision, and that just kind of locks that in place so you can continue suctioning while you're still looking at the airway, and then get ready for your intubation. Okay, so, this next slide is one that we go over every month in our QA meetings. And so I just thought it'd be beneficial to share this information with you because this is what we're looking at every month as far as Airways. So, the national standard for first pass innovation is 80%. So back in 2021, we had a 72% innovation success rate. It wasn't on our first attempt, it was just, did the patient get a successful intubation? And so in 2021, we were only 72%. In 2022, we jumped up to 85%, so we did a lot better. In January of 22 is when we first got the King Visions. We took a big decline in our successful intubations when we first got them, but then a few months later, when we had our Airway in service and we practiced using it and went over some different techniques with it, we shot back up and we're doing really well. This is the first year that we started tracking on here the successful intubations on first attempt versus did they just get a successful intubation. So this white line is going to be first attempt intubation success rate. We started pretty strong at the beginning of the year, and we've kind of been falling a little bit. So like for June, our first pass success rate for intubations was only 62%. But when we had multiple attempts, either 2, and it wasn't very often, but sometimes 3 intubation attempts, we did jump back up to 90%. And then the month before, we were at 71 on our first attempts, but with multiple attempts, we were at 100%. So, like I said, our goal is to try to get a successful intubation on the first try. And with the national standard being at 80%, right now, currently, we are falling below that for the last several months. But before that, January, February, March, we're above 80% for those 3 months for our first pass. So that's why I said just at the beginning, just take your time today at all the stations, really practice these different scenarios, use the different tools, get comfortable with everything, and we'd really like to get our percentages back up there. Okay, so there's been some things going on about just like documentation and documenting pertinent negatives. So when we have things like unable to obtain a blood pressure, we're going to document other things that go along with that. So if we can't get a blood pressure because either the monitor won't read or we can't get a manual one, then we're supposed to document other things like, well, they did have a radial pulse or they had a femoral pulse. That tells us that the patient did have some type of blood pressure, and especially if they're up and talking and things like that. That's stuff that we need to be documenting. If we don't have one reading, then we need to make sure that we're going into detail about other things that we're noticing. Same way with Airways and our O2 stats. There's been some documentation about can't get an O2 stat reading, but we should also be putting more detail into our narratives about what are some other things that we're looking for if we're not getting a good reading. So we can mention things like, did the patient have a nail polish on, or the acrylic nails, or was their hands cold and that's why we couldn't get a good reading. And then if all of those, if we're not getting a good reading, we need to be documenting other things. What's the color of the patient's skin? Are they reporting difficulty breathing? Or are they sitting there talking and they say everything's fine? What are the lung sounds like? And then just monitoring their other vitals, heart rate, respiratory rates, things like that. And the big thing is if you can't get one, but you think there might be something going on or you're not quite sure, then put the end title on. Check their end title. All right, just a couple more. So with kids starting back into school, in 2020 we started seeing an increase in RSV, and where it used to be something we just noticed in children, or in infants and younger kids, we're now noticing it in older children and even adults now. And they do present with different symptoms. So we're about ready to come into this come fall into spring. And then the difficulty with RSV is there's no medications that can treat this. We're just treating the signs and symptoms. And where children have to end up being hospitalized or they do get more sick, it's usually because the RSV has has developed into some type of bacterial infection, bronchiolitis or pneumonia, and that's where they have to get to the hospital and get in some more treatment. But there's only 1 to 2% of children that actually have to be hospitalized for RSV cases. Symptoms usually last about 5 to 7 days, and they're contagious from the 3rd day to the 7th day. In infants, you're going to see things like irritability, poor feeding, sometimes a fever, and then children, they're going to get a runny nose, a cough. The cough can be dry or it can be wet or wheezing or something, depending on where they are with it, and then same with adults. So this is a sound that you might hear from an infant who has RSV. I've never heard a child sound like that. Well, maybe you haven't had one.
Sounds like a little poodle. I had a girlfriend like that once.
So, this is our last slide, and then we'll break off. So, I think it was brought up at the last advisory group meeting, right? About breathing treatments and duonebs and our possible overuse for them. So, just wanted to review the differences of when we use albuterol and Atrovent. So we're going to give a breathing treatment with just albuterol if it's something that's acute symptoms, like acute asthma, or if it's a flare-up of like some type of episode with COPD, but it's an acute flare-up, and it's caused by triggers or irritants that they get. And so we're going to see the signs of asthma for shortness of breath, wheezing, coughing, chest tightness. And for that, we're just going to give the 2.5 and 3 milliliters of saline of the albuterol. When we need to go ahead and do a duoneb treatment and add Atrovent to it is when we start getting into chronic conditions like chronic COPD, bronchitis, and emphysema. So as we move forward, just kind of consider what really is going on with your patient, because a lot of times, I think most of the trucks have albuterol and Atrovent just taped together, and it's just easy to go ahead and pop those tops and pour it in there. But we really just need to figure out what is going on with the patient now and what do they need, and then treat them accordingly. So that's all I had for the slides. If you guys want to take a quick break, and then
So what triggered that conversation is the fact that Atrovent is going on back order and going to be a national shortage, so we won't be able to get it. And in that place, we still can get duoneb, so we'll be probably purchasing the duoneb, the pre-mixed medication to be off to the side.
okay.
So that's what brought the whole discussion up, so that's something that's probably coming forward in the next little bit, is Atrovent or ibuprofen is gonna be disappearing from that for a while.
So add that to the list of medications that. So just be aware that, like you said, if this is going to be something that we're going to have to deal with anyways, we need to start getting on board with treating our patient with what's really going on instead of just popping both of those open. Yeah. All right, so yeah, take a quick break and then split off into groups. Make sure you hit all the stations, and then again, once you're done with that, just turn those in, and then there's an evaluation up front.